Good day, friends. We are starting our second lecture about cardiac pathology. And first of all, accept my apologies for the absence of lecture in time due to technical fault. I believe you were expected very much my lecture, and so may I. I was expecting to meet you, so we are starting our discussion about very important group of pathology, cardiac pathology, and particularly about cardiac failure. In the whole world, in any country, this is still the first, number one, among reasons of both mortality and morbidity, despite the economical value, despite the stage of development of a country. In any country, in any part of the world, cardiac problems, cardiac pathology gives the biggest morbidity and mortality annually. And some more statistics. You can see morbidity among people older 45 is above 2.5%. You may say only, but it is 5 million people. And prognosis of this pathology is still poor. You can see a half of patients with cardiac failure dies during the first 4 years after diagnosis of cardiac failure was made. In middle course, in severe cases, the same number die during the first year. So much more short the life expectancy. So the severe condition is, the shorter life after the diagnosis is. So we shall understand better what leads to cardiac failure and what are mechanisms. What are mechanisms of this very important pathology? As you remember from previous year, the keystone of cardiac failure is the reduction of heart pump function. Pump function is performed by the number of functions of the number of events. First of all, it is contractility, the ability to contract of cardiac muscle. Then, the condition of cardiac valves. Only valves allow or do not allow the chambers to be filled and, as a result, to contract. The next function is the supporting of appropriate cardiac rhythm, the sequence between contractility and relaxation, and in electrophysiological value, it is the sequence of excitation, depolarization, and repolarization. It's very important. Normally, the rhythm is sinus. When excitation starts in sinoatrial node and then spreads in conducting system up to the myocardium. And the last one is venous tone. As you remember, cardiac muscle can contract only when it is stretched enough by returned blood. So we know we distinguish four reasons for cardiac failure. First is about myocardium. It is the direct myocardial damage. Then abnormalities of the heart. It means valvular abnormalities. The third one, arrhythmias, significant arrhythmias, just later about this. And the last one is low venous return. Now let's see what about each group of reasons. In the group of direct myocardium damage, number one is myocardial infarction. The most frequent, the most severe reason of cardiac failure in the whole world. The direct consequence of myocardial infarction is cardiosclerosis. Both infarction and sclerosis are able to produce cardiac failure. Also, non-ischemic damage like myocarditis, myocardial dystrophy, and cardiomyopathy of acquired and inherent nature also may significantly decrease pumping function, because all of them lead to inappropriate structure and function of cardiac muscle. So, pumping drops sometimes critically. Heart abnormalities, valvular abnormalities, and here the main pathogenic mechanism is the overload of myocardium. Arrhythmias. Here we mean only types with significant drop of minute volume. Here you can see some of them. The most dramatic is ventricular fibrillation, of course. When, due to abnormal excitation and what is more, abnormal propagation of action potential, when action potential actually doesn't propagate from one to another fiber, from one to another cell, as it normally happens, and only separate fibers excite and contract. So you understand, in this situation, output drops critically, as well as in blockages. You can see the lowest ECG demonstrates blockage where quite a long period of asystole exists. So electrical asystole accompanied by mechanical asystole, absence of contraction. So pumping function is impossible here. Low venous return. To be pumped, blood should be returned, obviously, to cardiac chambers. When return drops, it happens in hypertrophic cardiomyopathy when due to thickening of cardiac muscles, thickening of chamber walls, no enough place to fill. Then in arterial hypertension also it happens. In pericarditis, when due to external compression of cardiac chambers, return is also insufficient. Also, lung artery thrombosis, when blood flow is interrupted. And in pneumothorax, again, compression of the heart by the air, which appears in pleural cavity. So, how do we classify? cardiac failure. According to previously given reasons, we may classify onto myocardial, overload by volume or resistance, or mixed type. Now let's see what types are included in each one. Myocardial, it is the primary damage of cardiac muscle. And again, the first one is myocardial infarction, together with their consequence cardiosclerosis. Also myocarditis, dystrophy, and cardiomyopathy. In all these cases, it is so-called myocardial cardiac failure. Overload type of cardiac failure happens if it is a primary intact healthy myocardium. It's very important. Surely, later myocardium may be secondary damaged, but primary it is a healthy tissue. The problem is that the heart works in excessive load condition. Excessive load may be by volume, excessive volume, or excessive resistance, vascular resistance, I mean. For instance, overload by volume happens in some valvular abnormalities or ventricular wall defect. Here in the picture you can see significant interventricular defect. And according to the gradient of pressures, blood goes to the place of lower pressure. So this chamber will be overloaded by volume. And finally, this chamber dilates under the excessive pressure. Overload by resistance, the second type of overload cardiac failure. It is caused usually by some valvular stenosis, for instance mitral stenosis, or by arterial hypertension. It may be valvular resistance or vascular resistance, like in arterial hypertension. And it leads to myocardial hypertrophy. First of all, it leads to hypertrophy, but after the time, if overload by resistance increases, maybe dilation and dystrophy. For instance, mitral stenosis happening as a result of rheumatic fever. If repeated attack of rheumatic disease leads to more and more narrowing of mitral valve, left atria is forced to perform more and more effort to pump the blood through this very narrow mitral valve. But myocardium here in left atria is thin. And finally, instead primary hypertrophy happens dystrophy, dilation, and failure. As well as in left ventricle in response on arterial hypertension. If vascular resistance is so high that left ventricle performing very high systolic pressure is unable to pump all the blood against this resistance. Also, dystrophic and remodeling processes take place in left ventricle, and again cardiac failure develops. But the stage of hypertrophy is quite long in comparison with previous one, when overload by a volume took place. And also mixed cardiac failure is possible. It is the combination of previous two overloads by volume and resistance. For example, in rheumatic fever, if rheumatic process, autoimmune damage, involves both myocardium and valves, maybe combinative type, mixed type, because myocarditis leads to myocardial type of failure. But valvular abnormality leads to overload cardiac failure, depending on the abnormality. It may be overload by resistance or by volume. Except previous, cardiac failure may be classified according to cardiac cycle phase, which is injured. And it may be systolic, diastolic, or mixed. Systolic type. Obviously, the main thing which happens here, it is the dropping of cardiac output. And systole drops, systolic effort, cardiac output drops, first of all because of contractility decrease. Again, direct myocardium injury by necrosis, sclerosis, inflammation, dystrophic, and other abnormal processes. It is the most frequent type. Among others, it happens in 70–80% of all cases of cardiac failure. Diastolic type. It happens more seldom, but sometimes we shall take it into account. The failure of diastole here is here, or failure of filling of ventricles because of their compression or tension. When it happens in arterial hypertension, pericarditis, in amyloidosis also, and here ventricular filling is reduced. About 20–30% of all cases is diastolic, but it is also important to remember. Mixed type. It happens potentially in arterial hypertension. Primary, it is diastolic cardiac failure. But if we think a bit, if diastole is insufficient, so filling is insufficient too, but systole depends on filling. The less filling is, the more diastole drops. So finally it happens mixed type. Also systolic is added. Systolic problems are added here, so in it, which happens in arterial hypertension. According to minute cardiac volume, we can classify onto two types. I shall recall you that cardiac volume depends on stroke volume and heart rate. Obviously, cardiac failure, it is the problem of output and minute volume. The majority of cases is characterized by a low minute cardiac volume. But it's very strange, but some cases may accompanied by high minute cardiac volume. Only in some cases, like hyperthyroidism, significant anemia, and pheochromocytoma. Why here is high minute cardiac volume? Because in these cases, in some cases, other also, but we do not include here. So, what happened in these cases? You know that in hyperthyroidism, in anemia and pheochromocytoma, especially in two hormonal disorders, the problem is very high cardiac rate, tachycardia. So temporary, I shall underline, it is temporary event, temporary due to tachycardia. Minute cardiac stroke volume and minute cardiac volume are both elevated. But the longer situation exists, the more problems are in cardiac muscle because of constant tachycardia. Especially if it is a bad progress in hormonal profile. For instance, more and more thyroid hormones are synthesized, are released. More and more catecholamines are released in pheochromocytoma, or less and less erythrocytes are more significant anemia. So, if cardiac rate comes up to the border level, we remember that border level for even a healthy person is 120 beats per minute. After this level of tachycardia, the filling of ventricles is reduced due to the shortening of diastole. The shorter diastole is, the less filling is. So output and minute volume start to drop. And minute cardiac volume, even in these situations, drops and converts onto cardiac failure with low minute cardiac volume. So it is a temporary situation where in cardiac failure, minute cardiac volume is increased. A more practical classification is made by New York Heart Association, so-called functional classification of cardiac failure, which takes into account three groups of symptoms or things. First is limitation on physical activity. Then symptoms of cardiac insufficiency like fatigue, palpitation, dyspnea, or pain sometimes. And how do the symptoms interact with physical activity? And the third thing is status at rest. So, according to this classification, we distinguish four so-called functional classes. Let's shortly describe them. First functional class. The most favorable condition, because no limitation on physical activity, no symptoms with ordinary physical activity, and at rest a patient is comfortable. But you must be confused. Where is cardiac failure here? Nothing was found. But I underline limitation is on an ordinary physical activity, where no limitation. But if we specially add additional physical activity, unusual physical activity, we anyway can find that reaction of this unusual load will be not normal. We usually measure blood pressure, pulse, ECG as well, and take into account the changes. If changes are beyond the borders of norm, we are talking about the first functional class. The second class. The patient is still comfortable at rest, but see here, slight limitations on physical activity already exist. What does it mean? For instance, your patient complained that recently, last months, he has some problems with the climbing on the 5th floor. He lives on the 5th floor all his life and climbing every day several times. But last 2 months, some problems are here and he is forced to take some rest at the 3rd floor. And that's all. Nothing else happened. It is ordinary activity for this patient, so some symptoms exist. So fatigue is here in this activity, some palpitation maybe, not obligatory pain, not obligatory cyanosis or edema. So patient still active, still is able to perform their job and so on and so on. But the problem is that without correction, if patient doesn't pay attention a lot to this fact of limitation of activity, and furthermore, if a doctor doesn't pay attention to this functional class goes to versa, because the process which initiated the appearance of cardiac failure without treatment goes to bad progress. So it goes to the 3rd functional class. What can we find at the 3rd functional class? The limitation of physical activity is marked, obvious. So patient now complains that he is unable to climb to the 5th floor without 2 or 3 periods of rest. And furthermore, he noticed that performing of daily activity, not only climbing, of any ordinary daily activity, now brings some fatigue, more and more fatigue, furthermore, more and more fatigue, and even cardiac pain now is here. Also, edema formation is obvious, and even he noticed some cyanosis. But at rest, these symptoms are released. And finally, the 4th, the most significant, the most severe functional class is characterized that symptoms that patient is unable to perform any activity, even very small activity. For instance, even waking up in the morning brings sharp pain, brings increase of dyspnea, appearance of total cyanosis, and so on and so on. And patient is discomfortable with any activity. And even at rest, patient has symptoms of cardiac failure. And of course, the worsening of these symptoms are in any activity, even climbing, even waking up in the morning, changing the position from lying to sitting. in the moment brings problems, brings discomfort, brings decompensation. So, why do we need this classification, these functional classes? Not only for making diagnosis, but also to be able to reveal cardiac failure, because to each functional class, special appropriate working capacity may be found. There are special tables, special nomograms, when we can find the level of working capacity. But not only working capacity is important, but also we have some limitations of blood pressure and pulse to each functional class. Why do we need so? Because there are good news that almost each functional class may be turned back. For instance, the second one may be, in some conditions, may be turned onto the first, to less severe condition. Or even the third may be turned into a second, and then gradually to the first functional class. Through appropriate rehabilitation, appropriate treatment, but according to appropriate working capacity. Especially it is about training, because not exceeding appropriate pulse and blood pressure for quite long time of regular training may lead to the development of adaptation, especially, first of all, it is physiological myocardial hypertrophy and improving of cardiac output, improving of pump functions, and relief of the majority of symptoms. Even post-infarctic patient may be rehabilitated. Of course, what about the fourth functional class? It is questionable. Is it possible to change it into even the third functional class? Because it is severe decompensation with secondary target organs involvement, but previous three, there are plenty of examples in many countries that people been rehabilitated gradually, seriously, managed to turn their functional class to less severe. Now we are talking about some theories, some models of cardiac failure pathogenesis. Early people notice that cardiac function drop lead to severe problems, and early people tried to explain how it happens that the heart doesn't perform their functions anymore. And historically, the first theory, the first model is cardiac or systolic model of cardiac failure. As we told previously, according to this model, cardiac failure is the result of hemodynamic disorders because of contractility dropping. So the central position is the drop of contractility, the fail of contraction. According to this theory, what shall we do with this cardiac failure? We shall add cardiac glycosides. As you know, I believe you know this, cardiac glycosides are included into the group of drugs which improve contractility through the improving of filling of ventricles. Mainly they prolong diastole. And we know that the longer diastole is, the better following systole will be. So the better contraction is. And cardiac glycosides are used quite a long time historically in Europe from the 18th century, and they are still used in the modern medicine. Still, the most modern recommendations for the treatment of patients with cardiac failure still include cardiac glycosides. Nothing better was proposed. The second model, which was proposed historically, it is cardio-renal model. The science, the medicine has been developing, and renin-angiotensin-aldosterone system was discovered, and their interaction with cardiac activity, vascular tonus, and fluid exchange also was described. So according to this model, contractility and electrolytes delay are important. Not only contraction, but also interactions between electrolytes and water exchange, which support also both vascular tonus and circulatory volume. So contractility really depends on circulatory volume, we know, depends on venous return, which depend on electrolytes and water level. And disturbance of both contractility and electrolytes exchange lead to cardiac failure according to this model. So how to treat? Still cardiac glycosides supporting venous return, supporting appropriate diastole, and additionally diuretics and angiotensin converting enzyme inhibitors. As for diuretics, we know that nowadays many diuretics are proposed every year, I must say. New drugs in this area are proposed, and so what diuretics are the most useful according to this model? What shall we avoid from? We shall avoid from the excessive loss of some ions, especially potassium. As we told, loss of contractility leads to hypoxic condition, hypoxic state, hypoxic injury of one or another degree, and one or another degree of ion disbalance, particularly loss of potassium from intracellular space. Especially, it is dramatic in cardiac muscle, because potassium, as we remember, it is the key ion for cardiac muscle excitability. The less potassium concentration intracellularly leads to the drop of excitability, inability to action potential to be initiated and to be propagated through all the myocardium, and as a result, inability to heart to contract. So, diuretics, preferable diuretics, are potassium-safe diuretics, like antagonists of aldosterone or some other similar drugs. And together with angiotensin converting enzymes inhibitors, which stop at the upper level of excessive stimulation of angiotensin release and aldosterone, following aldosterone stimulation, following ADH stimulation, and excessive sympathetic activity, by the way. So these inhibitors of these converting enzymes are very useful if this system is activated. Next model, cardiocircular model. It is based on the number of hemodynamic laws. You know them well. First of all is Frank-Starling law. We told some about this today and earlier. So, Frank-Starling law is based on the fact that the more ventricular fibers are stretched in diastole, the better they contract in systole. But here there is some limitation. The stretching shouldn't be more than 30% of final diastolic length of these fibers. If more, they are overstretched and become unable to contract. So it is the basis of dilative, so-called dilative dystrophy of ventricles, of myocardium. Except Frank-Starling laws, there are some other laws like Bowditch, unwrap, and sympathetic activation. The unwrap effect. It is autoregulative mechanism in which myocardial contractility increases with afterload to increase myocardial supply. And one more effect of phenomena, effect of ladder or Bowditch ladder. The higher frequency of stimulation of myocardium is, the greater is the force of heart contraction, and vice versa. So this is the variety of interactions between stimulation and the force of contraction. That's why, one moment, that's why, according to this model, what about therapy? Cardiac glycosides are still here, because according to Frank-Starling law, they allow to myocardial fibers to be stretched appropriately to contract better, and also additionally we use vasodilators to prevent excessive preload of the heart and to prevent excessive overload of myocardium. So the next model is neurohumoral. The problem is that progressive cardiac failure is connected with prolonged neurohumoral hyperactivation, both on circulatory and tissue levels. Compensatory mechanisms are converted into pathological, because in neurohumoral model we mean that compensatory mechanisms become ineffective, excessive, or inappropriate. What are these compensatory mechanisms? I believe you know them well. First from the first is sympathetic activation. Any hypoxia is a stressful situation. So in cardiac failure also, it activates sympathetic nervous system, release of catecholamines. The second well-known renin-angiotensin-aldosterone system, which is activated in response of lack of renal perfusion and leads to, on the one hand, strong vasoconstriction, on the other hand, sodium and water delay. Then endothelin. Endothelin is a local mediator, a local biological active substance which is released from endothelium in response on hypoxic state. Natriuretic peptide. It works oppositively to aldosterone. In some extent, it is released in response on excessive blood volume in right atrium, in some other places of our organism, and leads to natriuresis, to excretion of excessive sodium and water from our body. And one more mediator is nitrogen monoxide, vasodilative substance, which is released from endothelium also. So these are normal compensatory mechanisms, I must say, but we're talking here about hyperactivation of these mechanisms. Let's see what happens if hyperactivated. What if sympathetic system is hyperactivated? So the level of catecholamines becomes more and more, and instead the moderate level of tachycardia, which is able to support appropriate cardiac output, minute cardiac volume, it reaches tachycardia, it reaches to critical level, after which there is the drop of diastole and the drop of diastolic filling of ventricles. So what happened as a result? The drop of stroke and minute volume of the heart. So compensation is failed. As well as about renin-angiotensin-aldosterone system. If it is overstimulated, strong, prolonged, unreleased vasoconstriction takes place. As a result, heart is overloaded by resistance, which is increased by angiotensin, for instance. Additionally, due to aldosterone overstimulation, sodium and water retention, circulatory blood volume is increased. It is a positive event. Unfortunately, more and more hyperaldosteronism leads to a very high level of sodium, of water. So fluid is accumulated not only in circulatory volume, but also in interstitia, edema formation, and even excessively high circulatory volume leads to overload of the heart by volume. Again, overstimulation, overload, decompensation. Vasodilators may lead to excessive dilation, retention of blood in venous part of circulatory system, and congestion. So, According to this theory, how would we correct the condition in cardiac failure? So our therapy is still based on angiotensin converting enzymes inhibitors. Also, what do we add? Aldosterone inhibitors and blockators of angiotensin receptors, additionally to converting enzymes, to stop as more this negatively released compensation as is it possible. Surely we administer finally a lot of drugs as a result. Maybe you notice that each theory adds additional drug to the treatment. On the one hand, it is a positive event. So more and more selective, more and more targeting therapy, which works more and more selectively and allows to correct more and more mechanisms. On the one hand. On the other hand, unfortunately, the majority of these drugs are metabolized in liver. But we should remember that liver also is located in the body of our patient and also is in the state of hypoxia in cardiac failure. And the functions of liver are already inhibited. So, loading liver by these drugs, we forced hepatocytes to work more and finally may lead to their inhibition. So we shouldn't forget about this fact, because liver also, together with renin, angiotensin aldosterone system, plays a role in fluid exchange. If hepatocytes are inhibited, so they start to synthesize less useful substances, for instance, albumins. So, hypoalbuminemia leads to low oncotic pressure. If oncotic pressure is less, fluid doesn't return to the blood flow been filtrated before, as it happens in normal fluid exchange in every capillary, in every tissue. So the returning of fluid becomes problem, and it is one more mechanism of edema formation in cardiac failure. So we shouldn't forget about liver care. So these named mechanisms are activated in response on the partial myocardium loss of functions or loss of myocardium. However, they are insufficient. We talked about this on previous slide. And consumption cardiomyopathy develops. So-called consumption cardiomyopathy. So what is this? It is characterized by hypoxia of hypertrophic and electrically unstable cardiomyocytes, which have so-called calcium overload. So what is calcium overload? It is so-called calcium paradoxis or calcium overload, which happens in hypoxia. When we studied hypoxic injury, hypoxic necrobiosis, we told about the condition of energy deficiency, in hypoxia. And this energy deficiency, first of all, affects different ion pumps, sodium-potassium pump and calcium pump. Normally, after muscular contraction in myocardium, calcium is transported through these specific pumps back to their storage places, to the cistern. If you remember, in cytoplasmic reticulum, where it is stored before the next contraction. It is active transport with the usage of ATP. But in cardiac failure, in hypoxia, calcium, due to energy deficiency, cannot be transported normally, appropriately, back to cisterns. Because of energy deficiency, because of changes in these protein molecules which pumps are, so calcium stays inside of myocardium. What happened as a result? So-called calcium overload. In other words, myocardium is unable to relax properly. And there is a paradox. Contraction is already a problem because of different previous damages. And now, even relaxation becomes problem too. So, the so-called calcium paradox. Additionally, in consumption cardiomyopathy, the destruction of cardiac cells takes place through both necrotic or apoptotic mechanisms. Necrosis mainly of hypoxic nature. And what about apoptosis? We studied in the third year that apoptosis is a programmed cell death. So, why apoptosis? Because in hypoxia, maybe primary activation of specific apoptotic genes, which are responsible to the programmed cell death, and being activated, they initiate specific program-specific functions, specific events, which lead to cellular destruction and death. Additionally, apoptosis may be activated by secondary mediators, which are released during the hypoxic injury, which are released during the remodeling of myocardium. So, apoptosis is activated. And one more thing, which is typical to overload, to consumption cardiomyopathy, is hibernation of cardiomyocytes. What is hibernation? Cardiomyocytes are still alive in hibernation. But what happened? Their functions are significantly inhibited. And not only inhibited, and I must say they are turned onto very strange functions. For instance, a light exciting stimulus may excite cardiac muscles so much, and vice versa. When you studied Parabiosis at the second year, you told about stages of Parabiosis. First is stage of equal response, when any stimulus, despite their strengths, may initiate the equal response. Then, paradoxal stage, when small stimulus initiate very strong contraction and vice versa. And finally, it is the stage of inhibition, when nothing is able to initiate the contraction of myocardium. Here it is the same. Hibernation, it is parabiotic condition of myocardium, when myocardium is alive, but their functions is on minimal level. It is reversible condition, but anyway, this condition may lead to severe drop of contractility, of cardiac output, and as a result of perfusion of the whole organism. According to this theory, how to treat cardiac failure? According to this theory, inotropic stimulation is prohibited. So, inotropic, what does it mean? It is stimulation of the strength of myocardial contraction. So, it is useless according to this theory, because myocardium is in specific state and stimulation is useless. Instead, according to this theory, only negative inotropic remedies are prescribed. For instance, beta blockers. Now let's see, what do beta blockers do? They separately block beta adrenal receptors in cardiac muscle. And what happens? First of all, they relieve tachycardia, decrease tachycardia. As a result, if tachycardia is decreased, as a result, diastole becomes longer. If diastole longer, filling is better. If filling of ventricles is better, following output and minute volume become both higher. If output is higher, is better, so perfusion becomes better, and previously described negative compensation is reduced. So no longer more reasons for sympathetic stimulation, because less hypoxic stress. No longer reasons for renin release because of beta perfusion of kidneys and following release of aldosterone and ADH. No more reasons for stimulation of other biological active substances release, and additionally, beta output leads to better myocardial supply. So, myocardium has more energy, less myocardial, less hypoxic injury, and finally, ion disbalance is released. So, balance is restored, and gradually myocardial functions become better. And finally, some new theories, briefly about some new theories in cardiac failure pathogenesis. Some modern theories. First is systemic inflammatory response. According to this theory, in response on hypoxic injury, in response on any other injury actually, any damaged cell membrane, on any damaged cell membrane is initiated arachidonic cascade. Also, some other cascades may be initiated, But these substances are well known as inflammatory mediators. And these mediators may be released systemically in the whole organism. But the substances are not very favorable for cells, for blood vessels, and for parenchymatous organs. For instance, myocardium. They are harmful, they may damage directly myocardium and may decrease as a result their pumping function. We still do not know all about the initial factors of systemic inflammatory response, but anyway, it is proved that in cardiac failure, in many cases of cardiac failure, there is the increased level of some inflammatory mediators like tumor necrotic factor, for instance. Some cytokines also are elevated, and this situation is quite long. Now, among the cardiac failure predictors markers are such well-known protein as C-reactive protein. Its level more than 5 units for very long time, for quite long time, is considered a predictor of high risk of cardiac failure in near future, especially if a person has already atherosclerosis, has already dyslipidemia, or other risk factors. So C-reactive protein, as previously considered inflammatory marker, now is considered also the marker of cardiac pathology. Then we talked today some about apoptosis. More and more initiative factors are discovered, not only in myocardium, but also in many other tissues. And now there is a wide discussion about stress-initiated apoptosis, especially in cardiac muscle, especially in cases of so-called sudden cardiac death. We still do not know what sudden cardiac death is. Many theories are, and one of these theories is massive apoptosis due to emotional stress-initiated apoptotic factors. We still do not know all these factors, but actually it is a well-known fact that stresses affect cardiac muscle, and people who live with high level of stresses quite often finally have cardiac attack. Next theory is autoimmune. It is not new actually. We know a lot now about autoimmune mechanisms of rheumatic heart disease, for instance, but unfortunately not only rheumatic disease may affect cardiac muscle. Many autoimmune diseases like systemic lupus erythematosus, systemic scleroderma, other disorders may affect myocardium, endocardium as well, and cardiac valves and pericardium also. And so on these mechanisms are based some aspects of therapy, like immunosuppressive drugs, which may be useful in the treatment of autoimmune myocarditis, for instance. Polygenic therapy. Of course, we know well that many diseases which we 20 years ago consider absolutely somatic, absolutely acquired, and now it is well known that they are not absolutely acquired. They have some genetical basis, but the problem is that not a single gene is responsible for the development of these diseases. but the sequence of genes in different chromosomic pairs sometimes. And the second bad news is that these pathological genes are responsible for not directly for the disease, but for some small disorders. For instance, some genes, pathological genes, are responsible for higher sensitivity of sodium potassium PAP receptors for sodium. So sodium influx increases as a result in endothelial cells. As a result, edema of blood vessel wall, and as a result, high blood pressure. So very, very small abnormality. But as a result, it leads to systemic arterial hypertension. And we know well that many other cardiovascular disorders may be classified as polygenic disorders. Of course, we know well that familiar hyperlipidemias or familiar dyslipidemias are responsible for high risk of early development of atherosclerosis and following hypertension and heart attack. We know this well now. But we still cannot cope well with these disorders. Because even if we correct diet, even if such person keeps diet well, it doesn't protect this person against the early development of atherosclerosis, because only 30% of cholesterol every person receives from the diet. Other 70% are synthesized in the body, even in a healthy person. But what if this person has familiar dyslipidemia, which is characterized by very abnormal exchange of cholesterol, and endogenous cholesterol is guilty here, not exogenous. Exogenous doesn't matter, unfortunately. Of course, now we use modern drugs which are able to decrease even endogenous cholesterol synthesis, but we shouldn't forget that these drugs have many negative effects, many back effects, which may affect negatively other functions and even may provoke new diseases, additionally to cardiovascular pathology. But despite this bad news, we shall expect that our work as future doctors, as scientists, maybe will bring more knowledge, new knowledge in medicine, and even in the knowledge about the theories of cardiac failure, and maybe somebody of you in future will award a Nobel Prize in the cardinal treatment of all kinds of cardiac failure. I wish you good luck. Thank you very much. Our lecture is finished. Goodbye.